Okay, welcome back in for Policy Module 3. I hope you had a good break. Let's look at where we've been so far with the content we've covered and where we're headed in these last two modules. So we've covered what policy is, why it's important. We have examined how you can look up policy because it does change day to day, year to year, month to month. We've begun to look at how you can know what the policies are, but understand that they will change, and also how to stay aware of some of those changes. So we've begun to look at that, but we're going to look at that more in modules 3 and 4. We're also going to start to get a little bit more into analysis. We've begun that a bit already when we were looking in the module 2 at some of those policies, but we're going to go deeper with that in modules 3 and 4. In module 4, we'll also go into crafting policy, not in depth, but just sort of the highlights of that. Also some advocacy tips and getting into implementation and evaluation of policy as well. So let's get into module 3. So let's talk a little bit about analysis of policy, and we'll use that as a way to sort of look at a controversial issue around TANF, also known as Families First in Tennessee. And so when we're analyzing policy, we have to look at a lot of the different influences that exist around policy. You know, who are some of the stakeholders, who has opinions about the policy, what are some of the political influences about the policy, why does the policy exist the way it does, what are some of the values and principles that drive the thinking behind the policy, what are the intended goals of the policy, what are some of the unintended consequences of the policy. So looking at all the pros and cons of what works, what doesn't, and maybe where changes need to be made. So a really popular idea among the public is this idea of testing welfare beneficiaries, and particularly testing people who are applying for welfare benefits. And again, when we look at the general public, when they hear the word welfare, the program that they're actually thinking about the most often is TANF, and then SNAP as a close second. And so when they're thinking about testing welfare recipients, they're thinking about people who are applying for SNAP and people who are applying for TANF primarily. But they might also be thinking about people that are applying for SSI or maybe even TennCare in the state of Tennessee or Medicaid in other states. But you can see here a couple of memes or a couple of images that were shared around social media a lot and continue to be, depending on, whether or not the person even knows what the current laws are or what have you. But you can see here the one, you should have to pass a welfare check because I had to pass one to earn the welfare for you. So this idea, I'm a taxpayer, I'm working hard, I'm paying the way for you. And then over here, welfare, people who want welfare should have to pass a drug test, like if you agree, repost if you agree. So you can see this is very simple, simplistic even, policy analysis, just looking at sort of the very narrow level of analysis of what's going on here. And basically what's being thought is, okay, well, if I have a job and I have to be drug tested for that job, then people who want benefits for welfare should have to pass a drug test too, okay? Now stop and think about what the assumption is behind that. Oftentimes, a lot of the jobs that require drug testing would be jobs that there might be an issue of safety if the person was using substances. So maybe a heavy equipment operator or somebody that's working in a factory or a public transportation bus driver or something like that. Whereas a lot of other jobs wouldn't necessarily require, that type of level of scrutiny in terms of whether or not a person is using substances. The other assumption that's at work here is that people might assume that people on welfare are more likely to use substances than people who are not on welfare. And the research just doesn't play that out. It's actually not true. People on welfare actually tend to use drugs less than people who are not on welfare. The other assumption here is that possibly the reason they're not working is because they're actually on drugs. That's why they don't have a job to start with. Well, the truth is there's a lot of people who would test positive on a drug test, meaning they might show that there's drugs in their system, who go to work every day, right? Who are functional users, meaning they hold down a job. It's not affected their ability to hold a job or earn a living. So just the fact that someone is using drugs does not mean that that's the reason they're not getting a job, okay? So a lot of assumptions going on behind this particular approach to saying, well, I know one of the solutions, meaning that's what someone in the public might say, or a politician, let's just drug test those people on welfare, because surely a bunch of those are going to test positive, and therefore we can save a lot of money and make them, walk the straight and narrow and find a job, because if they get off the drugs, then they wouldn't need the welfare. Really simplistic understanding. You can understand why some people might think that way, and certainly why it would be a good idea to know if someone had an issue with drugs or not. And as social workers, we would want to help with that, right? But so let's go a little deeper into the issue. Now, one of the things is that as states have passed this law, and Tennessee was one of those that passed the law, even though they knew what had happened in other states, the law had been declared by the courts as unconstitutional. Part of what the federal appellate courts have said in reviewing the constitutionality of the welfare drug testing laws is that there has to be probable cause in order to test someone for drug usage. One way Tennessee's gotten around that is they have had the eligibility workers at the Department of Human Services, DHS, make determinations about who might be using drugs. So basically a suspicion-based testing. In other words, the eligibility worker had to have a reason to suspect the person might be using. But because that was sort of an inexact system, and quite often DHS hires people who are actually on welfare themselves to work as eligibility workers. So one of the ways around that they proposed was using this form that you see, which are 3 questions that ask about whether or not the applicant for welfare uses drugs. And they have to answer a yes to one of these in order to actually be tested. And some have proposed, well, this is too simple of a system and people could just lie, which of course is true, but it's the only way that Tennessee has currently figured out to try to avoid not violating the probable cause to create testing, yet not leaving it up to individual eligibility workers just to determine who they think might be using drugs, right? And so even with the drug testing system in place, when testing has actually been done, the results have shown that only 65 people in the state of Tennessee during the first year that this was done actually, tested positive. And that was a very small amount in savings in terms of the benefits that were not paid through welfare, yet it cost the state $23,000 to do this particular drug testing program. And this carries out in other states. It's different from state to state, but basically you can see that in Missouri there were just 4 positive tests, yet it cost the state $14,000. In Mississippi, just 16, yet $8,000. Arkansas, 2 tested positive, yet $14,000. So part of the idea here is, well, you're trying to save money by eliminating people who would be receiving welfare. Therefore, you're saving that benefit money and it could go to somebody else. But you can see that these programs actually cost more money than they save. Now, there's also the side of it where you're trying to get people help that might need help for drug testing. States vary on this. Some states say if someone's going to test positive, then we're going to help them get the help they need because that might help them become more employable, those kinds of things. Others say it's up to them to get the help that they need. When we look at the actual rate of using substances, it's pretty low for people on welfare. So again, when we're thinking about welfare, when the public is generally thinking about welfare and politicians think about the word welfare, they're thinking about TANF, right? So we're talking generally single moms on welfare. If you look at these statistics from this particular journal article, you can see that this is reporting on the prevalence of mental disorders over a lifetime, of mental disorders over a 12-month period. It also reports the lifetime prevalence of substance use disorder and also the likelihood that someone's going to use substances within a 12-month period, so within a year. Also looking at dual diagnosis or comorbid diagnoses, so a person using both substances and also that they also have a mental disorder. And then those who actually receive treatment for it, for both the mental disorder and then those people who receive treatment for substance abuse. And so what you see here, if we look at the blue numbers first, you'll notice that there's a lifetime prevalence of substance abuse disorders among those on welfare of 29%, meaning across their entire life. But within a given year, only 9% of the population that is on welfare is dealing with a substance use disorder. Compare that to the yellow numbers above, right? The numbers in yellow. So you have a lifetime prevalence of mental disorders of 53%. So, close to double of what the lifetime prevalence of substance abuse is. And then a 12-month prevalence of 44%. So in a given year, welfare recipients, particularly single moms that are getting close to the lifetime welfare eligibility limits. And again, on TANF, you have a 60-month lifetime limit, meaning in your entire life, you can only be on TANF for 60 months, then you can't receive it anymore. And so this was particularly done on the population of moms nearing their limits, meaning they've been on TANF for a long time. And so if the assumption is that, oh, well, it's because they're on drugs, you can see here that actually in a given year, only 9% of them are dealing with substance use issues. However, 44% are dealing with mental disorders, okay, in a given year. Yet you don't hear anyone saying, let's test people on welfare for depression. Let's test people on welfare for debilitating anxiety or for bipolar disorder, etc. You don't hear that, right? Because people don't want to talk about that. They want to make it something that you can blame people for and say, well, they're using drugs. That's the problem. But you can see from these statistics that even those people on welfare who've been there for up to almost their 60-month limit, their 5-year limit, that substance abuse disorders are not near as big a problem as mental disorders are for this population. If we look at the numbers in purple, we can see that only 21.7% of individuals who had a mental disorder actually received treatment for that mental disorder. So you have a 1-year prevalence of 44% of these moms having a mental disorder, but only 21.7% of that 44% actually gets treatment. So we're only talking about a fifth of that 44%, right? So only a fifth of them, which means that the other 4/5, the other roughly 80%, do not get treatment for those mental disorders. So here we know that 44% of these moms have a mental disorder, yet only 21% of that 44% are getting help. When you compare that with substance use disorders, you can see that 41% of individuals with substance abuse disorders in a given year are receiving treatment. So we're putting all of our focus on treating people who have substance use disorders and completely ignoring or not putting as much emphasis on, I would say, those that have substance abuse disorders within the single mom population who are on TANF and have been on TANF for a long time. So again, this focus on actually having substance use issues is misguided because the larger issue is mental disorders. And again, nobody is pushing for, let's do mandatory testing of welfare recipients to see if they have clinical depression, and let's pay for that treatment. Nobody's wanting to do that, right? And if we did, we wouldn't have these low numbers of like, there's just, 6% of people that have a comorbid disorder or 9%. You'd have 44% of that population. So if 44% of that population is dealing with a mental disorder, that might lead you to believe that this could be an area we might want to focus on to help improve the employability and the quality of life of those moms and the families that they support. So if we look at this next slide here, it goes a little deeper into the same study. You can see again that 44% for anyone with a mental health disorder. With mood disorders, they're saying major depression, bipolar dysthymia. Under anxiety, you can see that 39% had anxiety issues, with 9.3% having post-traumatic stress disorder, which we'll come back to in a little bit. You can see the other anxiety issues there. And then if we look at substance use disorder, you can see drug abuse, drug dependence, alcohol use, alcohol abuse, alcohol dependence. So you can see the majority of that 9%, like 5.1, 2.4, 2.7, it's alcohol-related issues. And if I'm not mistaken, let me jump back to that question, the questionnaire, and you can see there's nothing here about alcohol on this testing question that's being given to individuals. It's just covering marijuana, cocaine, methamphetamine, other amphetamine, and opioids or opiates. And so there's nothing there about alcohol, but alcohol, you can see here, is roughly what? The majority of the people that are dealing with substance use disorders are dealing with the alcohol usage and not so much drug abuse or drug dependence. I would like to point out that substance use issues are mental health issues, but we tend to separate those, unfortunately, and hopefully one day we'll just talk about it all as being health and not even a separation into mental health. Now, if we focus again and look at that post-traumatic stress disorder number of 9.3%, I would point out that likely a lot of those with a mood disorder like depression, bipolar disorder, or dysthymia, and then those with anxiety disorders actually probably have PTSD, or more specifically complex PTSD, but that's not been diagnosed like it should be because it's been left out of the DSM, the Diagnostic and Statistical Manual of Mental Disorders, for a lot of political reasons with the American Psychiatric Association. Hopefully that will change within the next iteration of the manual. But a lot of those folks that are dealing with depression, bipolar disorder, anxiety, probably the major cause of that is underlying trauma issues. And there is a field of study or focus around policy analysis that's now rising up called trauma-informed social policy. In other words, looking at social policy through the lens of trauma-informed care or trauma-informed policy, and understanding that the approaches we take to problems like poverty need to focus on the underlying trauma. And in this article by Bowen and Murshid, they make this argument. Because a social determinants of health perspective drives public health toward an emphasis on promoting health in all policies, we argue that the principles of trauma-informed care constitute a meaningful framework for analyzing social policy and guiding advocacy efforts. So they're basically arguing taking a trauma-informed care approach and applying it as a lens through which we analyze public policy. If we look at this article by Dugan and colleagues, you can see it studied the effects of trauma-informed curriculum on depression, self-efficacy, economic security, and substance use among TANF participants. So basically, women primarily who were receiving TANF went through training programs that included content on trauma and how to heal from trauma. And they looked at how does it affect depression, how does it affect self-efficacy, and self-efficacy is basically your belief and your ability to handle what life throws at you, economic security, and substance use, which we've just been looking at, people being concerned about substance use in TANF. And what they found in their study was that trauma-informed peer support programming improves economic security and self-efficacy and reduces the co-occurrence of depressive symptoms and alcohol use. If we look at this article from Weeda, Egan, and Chilton, how trauma-informed programming to treat social determinants unveils challenges to system alignment. They're talking here about how they have reviewed the literature and examined what's happening in all the states, and they say, we demonstrate that addressing the social determinants of health will not fully succeed unless we seek to undo the punitive culture of compliance. Okay, that's an important thing I want you to keep in mind. We're going to come back to that, getting away from punitive compliance. They propose instead that we should incentivize states to provide innovative programs with a focus on the promotion of overall health and well-being to shift the culture within TANF programming away from one of compliance towards one of healing and longer-term transformation. So away from compliance and punitive compliance and more towards healing and longer-term transformation, and to engage in systems-level approaches to address institutional racism and discrimination within public assistance programming, including reparations. And then finally, they said effective systems alignment and the integration of trauma-informed healing and human-centered interventions into public assistance programming can address social determinants of health, foster wealth, and promote well-being among families, potentially leading to a more equitable society. And in this journal article from October of 2021 from Psychiatric Services, Smith and colleagues looked at improving maternal mental health as a pathway to economic mobility in the TANF system. And basically in their study, what they did is they ran an 8-week CBT group for women participating in TANF. In their literature review leading up to making an argument for their study, they say this: in light of the documented high levels of depression symptoms among women receiving TANF benefits and a robust research literature documenting the impact of maternal depression on child health and development outcomes, researchers and clinicians have advocated for the integration of mental health services within the delivery of social services such as housing and employment services for lower income families. This view reflects emerging policy and scientific perspectives that individuals with mental health conditions may be better served through interventions addressing multiple social determinants of health. So basically saying, hey, if we want to improve things for TANF beneficiaries, the women and children, and again, primarily women benefiting from this, we're going to have to look at addressing trauma-related issues. And here's just the highlights of their study. So the staff that were delivering TANF services were trained in delivering CBT to parenting women. And in the article, they go into that they had a ratio for the number of clients per licensed clinical social workers or licensed psychologists that they hired to deliver the CBT. The CBT intervention reduced depressive symptoms and stress among women, and delivering CBT in the TANF system may be a scalable model to address maternal depression among TANF recipients. So here is a program who's actually tried to address the fact that depression is a bigger problem than is the substance use that others might point out as being what they think is the biggest problem. And I would also add here that what we know from substance use is quite often it's a form of self-medication for depression and anxiety. And often the depression and anxiety is a symptom of the underlying trauma. There's organizations like the Campaign for Trauma-Informed Policy and Practice, CTIPP, and their policy agenda includes trauma preventive policies that reduce trauma exposure and enhance resilience, trauma-informed policies that mitigate the effect of trauma exposure, and then trauma-specific policies that improve access to trauma-focused services. And what they've uncovered in their studies there at CTIPP is that trauma-informed policies and practices improve health and reduce medical cost. So PTSD symptom prevalence down 63%, problematic substance abuse down 65%, physical health complaints down 86%. So obviously, addressing trauma issues helps to drive down these things that we might be concerned about within the beneficiaries of the social welfare programs that we've been talking about. Roughly $748 billion is spent each year on healthcare problems that are attributable to ACEs, which are adverse childhood experiences. If you address that with trauma-informed care, you can look at saving the federal government roughly $217 billion per year. So trauma-informed care is not only effective, it's also cost-effective. CTIPP says these are the four things that we have to focus on when we're looking at policy. Realize that the widespread impact of trauma plus possible plans for recovery are there. In other words, realize that this is an issue. Trauma is an issue. Be able to recognize the signs of trauma. Respond by integrating trauma science, knowledge into policies and practices. In other words, actually use the science that we have and help our policies be shaped by that science. And resist re-traumatization by protecting against dynamics that may replicate trauma. So if we go back to that idea of policies that are punitive and that focus on compliance, make judgments about saying that they might be more likely to use drugs. Or how about an assumption that says that they don't care much about their children's performance in school? Several years ago, Stacey Campfield proposed a bill that would cut TANF benefits to families based on their child's performance in school. So if the child was not doing well in school, they would cut the family's TANF benefit amount. Now, he purported that this was a way to increase family involvement in education. All right. Now, again, what's the assumption here? The assumption here is that families that are receiving TANF benefits are going to be less likely to be involved in their child's education or care about it. So when you look at cutting families' benefit amount, you're putting tremendous pressure on children, including elementary age children, because this was covering all grade ranges, and on families. And basically doing what the last thing we saw here from CTIPP is basically a re-traumatizing of families. Children are under enough pressure already. Teachers that teach them are under enough pressure already. Basically, he thought this would save the state money. This, unfortunately, went all the way through committee. I took a group of MSW students to Social Work Day on the Hill, where we actually met with Campfield, and he was not the best to deal with. I'll just put it that way. But ultimately, he told us that all these things that we were talking to him about were our problem and not his. That was his words, which was a bit disappointing. But unfortunately, this made it all the way through committee. It got to the floor to be voted on. And thankfully, enough teachers from around the state called their representatives and told them, please do not vote for this bill. To have teachers speak up and say this would be put too much pressure on the children in our classroom, and honestly, too much pressure on us. And obviously, it's just a bad idea all the way around. Things you might want to remember from Module 3, what are some of the assumptions that have been made by misguided policymakers about the beneficiaries of TANF? Has drug testing TANF actually saved states money? What is more prevalent in TANF, drug and alcohol issues or anxiety and depression issues? What is trauma-informed policy? What have studies about including trauma healing content into TANF services shown? And then also, a proposal by a Tennessee representative would have cut TANF to families if what happened? See you in Module 4.